The next presenters have promised that they won't make you cry, but if you're a techie, a nerd, and you love really cool apps, you may cry, because that's what you're going to hear about. You're going to hear about some 21st century communication tools to collect information and hopefully to provide information outcomes that can prove the value of some of these technologies that we saw in the first session. So it's my pleasure to present for the first talk, to talk about the usability of the Canadian Bleeding Disorder Registry, CBDR, Shannon Lane, who's a researcher at McMaster University. So Shannon.
So thank you and good morning, everyone. Today I'm going to share some highlights from the preliminary analysis of a study looking at usability and user experience of CBDR and MyCBDR from the perspectives of end users. So we would like to thank the study funder, the Canadian Hemophilia Society and Pfizer's Care Until Cure research program, and I just have the one disclosure. So I'm presenting on behalf of the study team, and this study has also been guided by a very active study advisory committee. And I'm just going to speak very briefly about the background and rationale for the study objectives. I'll define some terminology, and then I'll give an overview of the study design and focus on sharing some of the results that I think will be of greatest interest to this audience. So beginning in July of 2015, MyCBDR and CBDR were introduced in Canada to replace CHARMS and the Canadian Hemophilia Registry, as well as patient record-keeping systems. And the system was gradually rolled out across the country, and most of the HTCs were finally implemented, I think, in around June of 2018. So the CBDR interface can be used by clinic staff in HTCs to improve data collection for patient care, utilization monitoring, and clinical research. And MyCBDR can be used by people with hemophilia, caregivers, and parents in the home to report bleeds, record factor use, and for disease management and care. So the specific objectives of the study were to explore and understand user perceptions, attitudes, and feelings about the system, to identify any challenges or difficulties that users were encountering, to determine whether and how user perceptions changed over time and with repeated use, and then to use these findings to develop some recommendations to improve the usability and user experience of both systems. So to pursue those study objectives, we used a before and after mixed method study design with all data collected using WebEx web conferencing. At time point 1, the purpose was to collect data from both groups before they'd had the experience of using the system, using 3 methods, which included the Think Aloud, an interview, and the system usability scale. And then during the Think Aloud, participants were asked to work through sort of 9 representative tasks using test data and a demonstration version of CBDR or MyCBDR while thinking out loud and sort of verbalizing their thoughts, their feelings, their opinions. And then the plan was at time point 2, we would do a second assessment after routine use using only an interview and the system usability scale. Unfortunately, we were unsuccessful at recruiting MyCBDR participants for the pre and post version, so we implemented an interview component, and individuals were eligible regardless of how long they'd been using the system. The Think Aloud and interviews were analyzed using the techniques of qualitative content analysis, and the SUS score was generated, and analysis between the time points was compared and contrasted. So what I'm going to share with you today are the preliminary results from the interviews and the system usability scales. The data from the Think Alouds is a bit more system level and kind of technical, and so we'll save that for a manuscript. So a total of 24 people participated in the study. 11 CBDR end users completed time point 1, and 8 out of 11 time point 2, and 12 MyCBDR end users participated in a telephone or a WebEx interview that lasted an average of 20 to 30 minutes. CBDR participants' median age was 46. The majority were physicians, but there was also representation from nurses, a physiotherapist, and a social worker. And in terms of usability, when asked about their overall impressions of CBDR in the very first interview, the majority of participants found CBDR easy to use and fairly or very user-friendly. And these perceptions were unchanged when the question was posed again in the second interview. One individual, who identified as an Apple product user, indicated the system was not as user-friendly as other programs they were used to, and another, with a low self-reported computer knowledge level, felt that the system was not very intuitive in the first interview, but indicated in the second interview that they had learned more about how to use the system simply by exploring. So those results were mirrored by what we found with the system usability scale scores, which provided another measure of perceived usability. And so, as you can see, let me try to use this. As you can see up here with this red line, scores of less than 68 represented a poor perception of usability, but the majority of participants' SUS scores were over 68 at both the first and the second time points, and the SUS scores were not statistically significant, those differences between the pre and the post measurement. In terms of utilization, during the first interview, participants were asked about how they envisioned using CBDR, and the two main ways were to review the cumulative patient data since the previous visit in advance of a clinical encounter to obtain a snapshot of patients' treatment and bleed history. And the second was to review treatment and bleed records with the patient during clinic appointments or encounters, especially patients on prophylaxis, in a sort of educational capacity to assess and discuss any adherence issues and identify any potential breakthrough bleeding. Other participants plan to use this system in a variety of ways: to assess patient adherence, to look at treatment protocols, to review patient demographic summary information, to look at clinic level utilization and demographic data, and to look up patients' treatment plans. In the second interview, the majority of participants had the opportunity to review patients' treatment and bleed history, but only 2 had the opportunity to do so with patients during a clinic visit. And these 2 individuals believed that reviewing the data with the patients could help them to better understand the importance and the value of record keeping and potentially improve buy-in to the utilization of MyCBDR. A couple of participants indicated they had also used the system to assess adherence, to review patient demographics, and to look at some clinic level data and treatment plans. And PT physiotherapists indicated they had been entering the hemophilia joint health score at a minimum and hoped to be able to do some clinic charting down the road. In terms of usefulness of the system, participants were asked to comment on what they found most useful, and the common response included just being able to see what patients are doing, to see how patients are treating, how they're experiencing bleeds, and what the causes and the circumstances of bleeds are. And participants were also asked about the benefits of the system to themselves as providers, also to the healthcare team, and also to patients. And for healthcare providers, this system was seen as a good teaching tool to help demonstrate bleeding trends and factor utilization, and also gave access to all their patient data in one place to provide a good clinical summary of each patient. For patients, the MyCBDR system was perceived to be more convenient and easier to use. It could help patients see trends. Both systems could lead to better patient care and provide data to advocate for patient choice during the tendering process. Participants thought the system could benefit the HTC team of providers by providing all team members with the same access to information and better information to inform them about how patients are doing. So some challenge. Oh, thank you. Thanks. Yeah, click. So challenges to system utilization and uptake. There was a few identified by CBDR end users, and these included the labor and the time involved in initial data entry in getting the system up and running, and also some requests for clarification around which data to prioritize entering kind of right off the bat. There was also a lack of confidence in some of the data that had been migrated from the CHARMS system, and institutional mandates to enter clinic notes in hospital electronic medical record systems resulted in duplicated charting or not charting in CBDR, and this was a barrier, perceived as a barrier to full optimization of the system. There was also some people who just felt they had a little bit of a lack of clarity around how to use the system to its full potential. So there was sort of a wish list, some things that people thought, some expanded capabilities of the system that people would like to see. One of those was maybe a notification when a patient has a bleed or presents at the emergency department. Another was a notification for MyCBDR end users about any product recalls. Notification every time a patient's data was sort of initially entered into CBDR so that the healthcare provider could then add them to their sort of patient list. The ability to send and receive annual review intake forms or treatment satisfaction questionnaires to patients. A messaging system that patients could use to get in touch with the HTC. And an easy way to export data from CBDR so it could be imported to a new hospital EMR system if one was implemented. So moving on to MyCBDR end user results. So the median age of MyCBDR end users was 37.5 years. The majority were using the system for themselves, and a couple were using it on behalf of their children. The majority of participants or the children whose parents were using the system had severe hemophilia. 7 were using the mobile app, 4 the desktop version, and 1 individual is using both. So in terms of usability, the reactions of MyCBDR end users were similar to those of CBDR end users. In general, participants' initial reactions to the system were positive. They found it easy to use, although 2 had gotten off to a rough start with password issues. They found the system easy to use after that. And in terms of utilization, MyCBDR end users were using the system to record infusions and occasionally enter bleeds that occur. The majority were recording very closely in time to when they gave their infusions. Several described recording infusions either just before or just after, and 2 described recording simultaneously while administering the infusion. 1 individual had used the system to review their treatment and bleed report after having a bleed and before clinic visits, and several others were aware of this option but hadn't had the opportunity to use it yet. So we asked people what their motivations were for using MyCBDR, and they described a variety of different motivations. The most popular one was just the simplicity and ease of use of the system. Other people were motivated by a sense of social conscience, and an obligation to demonstrate accountability and responsibility for product usage. A few individuals didn't really perceive too much of a benefit to them to be using the system, but did so out of obligation. And 1 individual spoke at length about how the MyCBDR app had a great value for him because he used the app as a tool not only to remember his every other day infusion protocol, but also to help him make decisions about the timing of infusions. He appreciated that the first thing that he saw when he logged in on the welcome page was the time since entering his last treatment. We also asked people sort of what they were trying to achieve by using MyCBDR, and several individuals indicated that by recording, by recording treatments and bleeds, they were keeping their clinic team in the loop and ultimately providing them with the information they need to help them with disease management. And they also identified a few issues that they perceived with the system. Several described some frustration with the high level of security required with the system password. And although they understood the importance of keeping their health information secure, they found some of the requirements, like the complex criteria of the password, having to change the password frequently and then not reuse previous passwords, made the passwords difficult to remember. 2 individuals pointed out a perceived flaw in the functionality of the system related to recording treatment, and that was the inability to record more than 1 point of bleeding when recording a treatment, and then being unable to select more than 1 reason for administering the treatment, which forced them to choose or select only 1 reason for giving the treatment. So as one person put it, all of those other things, all of those other reasons get lost in the data. Lastly, some anatomical terminology for recording bleed location was not understandable to some people. One individual described having to Google certain terms in order to understand what muscle was being referred to. And another person pointed out just the importance of making that language accessible to the diverse end users, such as children who might be using the system. So MyCBDR end users also had sort of suggestions of enhancements for the system that they would like to see, and one of these was notification when inventory is low, prophylaxis schedule infusion reminders that might sort of flash up on your mobile phone the same way as other reminders do. Positive reinforcement for recording treatments and bleeds and for going a certain number of days without bleeds, establishing a communication platform with the HTC for non-urgent or non-emergent issues, and maybe a function to connect parents to help them network. And then lastly, just the provision of some hemophilia treatment-related information through MyCBDR. So just to summarize the conclusions of our study, participants found that both systems were pretty easy to use, and the majority of CBDR end users have not yet had the opportunity to utilize the system to its full potential at the time that we were collecting this data, but they perceived the system to be useful and beneficial. And there are some challenges for some people to CBDR system uptake, and those might be overcome with some additional support and some training. MyCBDR end users are using the system to keep their treatment team informed and may be more inclined to use the system if they also perceive a personal value to doing so. And as I covered, there's lots of suggestions end users have for things to add to the system to make it even better. Oh, I got slow again, didn't I? So just to acknowledge, we'd like to extend a very special thank you to everyone who participated in this study and to the Canadian Hemophilia Society for assistance with study recruitment. Thank you.